Hello everyone, I am Dr. Ananya and today we'll be discussing about radiation oncology in AGMC. So today we have, please introduce yourself.
Hi, I am Dr. Shashank Jangid. I am from Mumbai. I am from 2016 batch. I have done my MBBS from MGIMS Wardha. Currently, I am pursuing MD Radiation Oncology in AGMC.
You're in final year, right?
Yeah, I am in final year.
Okay. Why you took up radiation oncology?
Actually, my interest was more towards physics and physics related branches. Till I was not able to get a very good rank in NEET. समवट पेपर खराब हो गया था और जैसे भी है, लेकिन फिर भी मेरा फिजिक्स की तरफ इंक्लिनेशन था और मेरे को मेन स्ट्रीम ब्रांचेस में एंड अप नहीं करना था. इसकी वजह से माय फर्स्ट प्रेफरेंस वाज न्यूक्लियर मेडिसिन और सेकंड प्रेफरेंस फिर आई एंडेड अप हियर.
Okay. So tell me, how many faculties are there in your department?
Faculties, 1 SR, senior resident, 2 assistant professors, and 1 professor and HOD.
How the seats are distributed in your department?
There are 3 PG seats in each batch. These are distributed every year. The algorithm changes.
Okay.
Actually, in my time, there were 2 All India seats and 1 was from state. My junior batch, they were 2 from state and 1 was for all India.
So alternate.
Yeah,
It's
alternate.
like alternate. Since we are associated with AGMC, GBP Hospital, but when it comes to radiation oncology, it is associated with Atal Bihari Vajpayee, Regional Cancer Institute, which we call RCC ABV. And so tell me describe your hospital, about the different buildings and different sub-departments within it.
Okay. So RCC, Regional Cancer Center, comes under AGMC, but our department is in separate hospital as such. Here we have 3 buildings. One is Charak, one is Dhanvantri, and one is Sushruth. The Charak building is radiotherapy building where patients receive radiotherapy. Here in this building we have 2 linear accelerators and 1 brachytherapy room, minor OT, CT simulation room, and treatment planning system room, TPS room.
Okay.
All of these are in this building. So specifically patient receives radiotherapy in this building.
All right.
The other building is Dhanvantri building. Dhanvantri building is ward cum radiation oncology cum medical oncology building. Cobalt machine is there, placed underground at underground level. And first floor and second floor are wards. Whole of RCC is 200 bedded hospital.
200 bedded.
Dedicated cancer hospital. Dedicated cancer hospital. 200 bedded. And on second floor, we have daycare chemotherapy. In a day, approximately around 150 patients receive radiotherapy and approximately 90 to 100 patients receive daycare chemotherapy. And the chemotherapy that continues in ward goes on. So in total, 120 patients receive chemotherapy per day and 150 patients receive radiotherapy per day.
So my next question is, so you are having OPD also. So on average, how many patients you come across in daily OPD?
In daily OPD, on an average, there are around 300 patients. 90 to 100 patients are new patients, newly diagnosed patients or newly referred patients. And other 200 patients are the patients which are on follow-up, already receiving different modalities of treatment.
All right. So describe your day as a radiation oncology resident, how your days go like.
So I wake up at around 8:30 to come to my hospital. My hospital starts at 9 OPD.
Okay.
So our days are divided. Means in a week we have 3 OPD days and 3 other days we say them as radiation cum ward day.
Okay, radiation cum
ward day. Okay. So I'll describe both the days. In OPD days, we come at 9, go straight away to OPD. For next 2 hours till 11 o'clock, we write chemotherapy for that particular day.
Okay.
All the patients who are receiving chemotherapy, we write chemotherapy for those patients. Means chemotherapy, immunotherapy, or targeted therapy, whichever the patient is on, we write that. It is a very rare opportunity that I got here to practice chemotherapy, immunotherapy and targeted therapy along with radiotherapy. So daily practice करते हैं हम लोग. उसके बाद में then comes then OPD continues till 4.
4. Okay.
4. Then further on the day ends. The day ends.
Alright.
After that, when we go for radiation come ward day, our day starts at 8:30. We come to ward, we give our rounds, we inform our consultant regarding the rounds. Then our consultant gives the rounds. Then we are free from rounds at around 12 o'clock. Then we come to this Charak building. So earlier on, we used to do like the initial time, that is from 9 to 10 or 10:30. I used to be here. I used to write chemotherapy for that particular day patients. Then I used to go, I used to complete my rounds before 9. Then I used to write chemotherapy. Then further on the rounds, the consultant rounds goes on. और उसके बाद में फिर वापस आने के बाद में then we do radiation planning here for that day. So in radiation planning there are two different radiation plannings. One is on cobalt and one is in linear accelerator.
Okay.
So cobalt being a older machine, so we have to plan on patient, means we have to mark the areas which are to be irradiated on that patient.
All right.
So patient needs to be present there.
Okay.
For planning of cobalt therapy. Then in linear accelerator the spectrum changes. A newer machine, a better machine, more advanced machine, and less radiation related toxicities compared to cobalt machine. So in this we first do CT simulation of that patient. We have a CT simulator here.
Okay.
We do CT simulation of that patient. Then after CT simulation, the patient's CT scan comes in our treatment planning system. We sit on our computers. We decide which areas are there which are to be illuminated to receive radiation. So we mark those areas, and we, along with medical physicist, we plan how many cycles, how many fractions of radiation the patient will receive, how many fractions means how many days.
Okay.
And how many grays means dose per fraction the patient will receive. So it is according to this. Actually, receiving radiation in cobalt machine compared to linear accelerator has few differences. Cobalt machine irradiates a more larger area. So grossly, if we have a larger tumor invading larger areas, like in cases, specifically in cases of CA cervix. So in CA cervix, outcomes were better from cobalt patients treated through cobalt for radiation therapy compared to patient treated through linear accelerator. We noted that in our hospital. So, and actually cobalt machine is a bit cheaper. Linear accelerator is a bit costlier. But here in our hospital, it doesn't depend upon the cost, because majority of the costs are covered through Ayushman. All the patients have Ayushman. So whole of the cost is covered through that only. Okay. Even chemotherapy, immunotherapy, targeted therapy, and radiotherapy, along with surgery also. Okay. Actually, I forgot to tell about the third building. The third building is Sushrut building. It is a 7th-floor building in which on first floor we have our OPD. On second floor we have our radio diagnosis department. In radio diagnosis department we have a CT scan machine and one MRI machine and 2 USG machines. Then on third floor we have our office, means RCC's office. Then on fourth floor we have our ward, that is surgical ward. Surgical ward. Surgical ward is further subdivided into surgical oncology ward, gynae oncology ward, ENT oncology ward. Then on fourth floor only there are cabins, means patients who don't take Ayushman or the patients, selective patients, we have cabins for them. Then on fifth floor we have post-surgery ICU, surgical ICU. Post-op patients are kept there. On sixth floor we have our OT. Okay. Then on seventh floor we have our CSSD, Central Sterile Department. So that's whole of a surgical building. Dhanvantri is whole of radiation oncology plus medical oncology building, and this Charak building is whole of radiation oncology building.
So till now we have he has briefly described about a day in his life and also the different components of the cancer hospital. So just tell me that as a radiation oncology resident, do you have like night duties, emergency duties?
Yeah, we have night duties, we have emergency duties. But actually, one of the main questions of newly attempted NEET PG paper, the students, is that it is not an emergency branch, and what kind of emergencies are there and so on. So yeah, not an emergency branch. I totally agree with that. Very good work-life balance. I totally agree with that. But there are emergencies in cancer patients, like tumor lysis syndrome, seen in many patients. Then the carcinoma lung patients, they majority they face breathing difficulties and other means hemoptysis, repeated coughing, and patient not able to breathe, shortness of breath, and so on. Mainly the complaints are of pain, unbearable pain, and other things. Then in like CA ovary patients, there is massive ascites in those patients.
Right.
CA stomach patients, there is massive ascites. In CA lung patient, there is pleural effusion in those patients, leading to shortness of breath. Then in head and neck carcinomas, there are chances of means the patient comes with breathing difficulty. Actually, the patient presents with stridor. So emergency tracheostomy has to be performed in those patients for them to able to survive.
Right.
So that happens. Then further on, other oncological emergencies are there, but we have our days separately for that. So in a week we have just one night duty, and for initial years, not whole of the 3 years, for initial years.
First year.
Yeah. Then further on, emergencies are to be managed by us only, because not much of cancer exposure for other departments management wise is there from their side.
All right.
So we manage those patients, not a big deal. Means we have our good life also, along with if we want that emergency spectrum also, the management of emergency spectrum also.
Like what all PG activities happen in your department as a part of academics?
We have our classes taken up by our assistant professors, then by our HOD. Means they are very enthusiastic regarding our studies. They make us enthusiastic regarding our studies. So actually, one of the main things which they notice, that radiation oncology per se as a branch is not much exposed during MBBS times. So radiation oncology greatly deals with physics. So physics in particular being taught by them, after that we revising that going home helps us greatly to understand the thing, rather than by ourselves doing it again and again and again and memorizing like systemic oncology, because physics is a thing which you have to understand. Yeah. And other thing is, in PG activities we have our seminars, we have our journal clubs. Weekly there are two seminars, one journal club, and the classes goes on, which are taken up by them.
Are there any classes for you to teach to undergraduate students?
Yeah.
Is this happening now?
Yeah, it is happening now. So there are a very particular topics which we teach the MBBS students, because MBBS students, they don't greatly deal with carcinomas. So actually we have integrated with medicine department to teach regarding the liquid malignancies, that is lymphomas and leukemias. Actually the genetic mutations that happen in leukemias, and lymphomas classification, according to the classification, the treatment that goes on. These are some of the questions which are asked even in NEET exam. Yeah.
Okay. So the next question I would like to ask you is that how's the journey of a patient when a patient enters in your department OPD as a cancer patient? First of all, tell me about the referral system and how the system works.
Okay.
Yeah.
So, being in a cancer hospital, there will never ever be a patient arriving in our hospital saying that मैं आपका हॉस्पिटल में आया हूँ, मुझे कैंसर है इसीलिए. The patient doesn't know. So all the patients will be referred from general physicians and general surgeons, either gynae surgeons and ENT surgeons, etc. So patients will be referred from them if they suspect any cancer in those patients. Then the patient comes to our hospital. Two types of patient come to our hospital. One is the patient who has already done his or her investigations outside and has a confirmed report of cancer. Then the patient comes here. And the other type of patient is the patient, there is a visible growth which the primary physician is suspecting to be cancerous, and then the patient arrives here.
Okay.
So I'll try to explain that patient, journey of that patient, how the patient goes through processes. So patient comes in our OPD, then we register the patient in our hospital first of all. Then further on we do the routine blood work of that patient. After doing blood work, the patient is scheduled for CT scan. I know that having soft tissue tumors, MRI more better investigation, but still CT scan is preferred because faster investigation, faster reporting and other things. So patient is scheduled for CT scan, patient does CT scan, then the patient is scheduled for biopsy. Either of the two are there. In specific carcinomas or specific cancers, there is endoscopy guided for CA esophagus, colonoscopy guided for CA colon, or CT guided for CA lung or CA liver, and whole other spectrum is there. So these investigations are for biopsy. Biopsy being a gold standard investigation for confirming cancer in a patient. Without biopsy report, we don't register those patients here. Now when the patient arrives and the patient gets registered, if the patient has a biopsy report from outside, the patient is directly registered as a cancer patient. But if the patient has patient doesn't have any of the scans and all those things, so the patient is NR.
Okay.
Gets a temporary number. And after confirming through biopsy, we give them the permanent number. Then after that, biopsy is done. After confirming the patient has cancer, then we have a tumor board here.
Okay. Tumor board.
Tumor board. So tumor board is a place where all of the radiation oncologists, the radiologist, oncopathologist, oncosurgeon, gynae oncologist, and ENT oncosurgeon, all of us sit on a single table and discuss regarding the patients. Whenever a new patient arrives, whole of these multimodalities are discussed, that how patient treatment or patient's management will further proceed on. So each and every department gives his or her input, and accordingly the patient is managed. We stage the patient, we look into the NCCN guidelines which are given, then we discuss it, because NCCN guidelines, these are the guidelines. We proceed through guidelines, but there are very few, certain specific cases in which certain exceptions are also given in NCCN guidelines. So we even consider those during management of that patient. So I would like here to elaborate on the fact that cancer treatment is not a single modality treatment. Cancer treatment is a multimodality treatment. The patient receives chemotherapy, the patient receives radiotherapy, and the patient the patient undergoes surgery. So all of these modalities play vital role in eliminating cancer from a particular patient. After that, the patient starts receiving the designed, whichever treatment spectrum we design, the patient starts receiving that. Suppose we take up a case, just for example, we take up a case of CA breast. So CA breast, in locally advanced cases or in advanced cases, we generally proceed from administering patient chemotherapy earlier on. In means initially the patient doesn't have IHC reports. IHC means immunohistochemistry reports.
Immunohistochemistry.
Yeah. So initially the patient doesn't have that. So ER, PR and HER2 status is not known for that patient. The biopsy sample is further sent for IHC, so that the patient further on is we look into that, is the are we continuing that patient post treatment on hormone therapy, or the hormones are negative and HER2 comes out to be positive in those patients. Then we further on go for targeted therapy like trastuzumab, etc.
Right.
So initially we administer the patient with 8 cycles of chemotherapy, AC4 and T4. Then further on we go for surgical management. Surgery, if we after 8 cycles of chemotherapy, we do a CT scan to look for the size reduction. If there is size reduction and if the node status of that patient, nodes are negative or so, then we modify the surgical management. Either we can go for modified radical mastectomy or we can go for lumpectomy, etc. According to post chemotherapy CT scan, we modify that. Then after surgery, the patient is scheduled for radiotherapy. So in radiotherapy, we plan those patients mainly on linear accelerators only for breast patients. In cobalt machines, majority of patients are of head and neck carcinomas and CA cervix. Majority of patients are those. And in breast, lung, liver, prostate, these type of cancers, not specifically liver, because not many patients are scheduled for radiotherapy, because chemotherapy comes out to be one of the best treatment modalities for either hepatocellular carcinomas or and so on. So not even chemotherapy, targeted therapy. Then further on we go for in a CA breast patient, radiotherapy, a linear accelerator, CT simulation is done. Orifit is made. Orifit is a device which takes the shape of the patient. For each and every patient, it is a different, the shapes are different. It is a thermolabile structure which takes the shape of the patient, and it is mainly for the immobilization of that patient. So the patient does not move during radiotherapy treatment. CT simulation is done. We do contouring after that. After contouring, we give to medical physicists. Medical physicists, they decide, means we decide the dose, PTVP, CTVP and GTV. So GTV not in CA breast cases, because post-op cases, post-lumpectomy cases, gross tumor, sometimes it's not there. So we irradiate whole of the areas. So these are in particulars which we and medical physicists both sit, and then we decide how is the linear accelerator, the machine that is there, it is to be rotated in and how many, means the schedule of the patient is decided, fractions of patient are decided, dose is decided, dose per fraction is decided. Then the other organs at risk, are they receiving the radiation dose within tolerance level?
Right. I would like to ask you a question regarding that since patients are undergoing chemotherapy, anti-cancer drugs are given, which are like earlier called cytotoxic drugs. So there is a possibility of having toxicity, which is side effects. So then what are usually the side effects and how you manage them?
Yeah. So one of the main side effects which we read, the go-to side effect from pharmacology is nausea and vomiting. And it occurs way more in chemotherapy. So in chemotherapy induced nausea, vomiting, we administer the patient on antiemetics like aprepitant and fosaprepitant. These drugs are given pre-chemotherapy so that the patient does not go through nausea, vomiting. Patient's main concern is if they will have their hair regrown back after receiving chemotherapy,
Right.
because in radiotherapy, we don't experience hair fall. Hair fall is mainly through chemotherapy. So when chemotherapy cycles get over, when the patient treatment get over, after that hair regrows. It takes time, but it regrows.
It regrows.
Then in radiotherapy, specifically radiotherapy induced toxicities, like there are skin reactions. Then in head and neck cases, there occurs edema of larynx, post RT edema, and other things. So means tracheostomy, etc., has to be done in those patients. Then in means there is fibrosis in CA esophagus patients, which lead to difficulty in swallowing for those patients. So we insert Ryle's tube as a measure. We take greatly into account the patient's nutritional status also, because receiving anti-cancer therapy has a great impact on your body. So if the patient is not healthy or not in that state where the patient, after administering either chemotherapy to that patient, the patient will take up and will be fine, because we don't want our patient, after managing those patients, the patient do not survive. So whole of these things are to be done for patients to survive. So nutritional status is taken into account, and yeah, these are the big side effects that patient experiences.
Okay. All right, Shashank, I would like to ask you that what in considering Tripura as it's the cancer center here is a tertiary care center. So what are the majority of the cases, cancer cases you have come across, and have seen a pattern that okay, these cases are more in northeast? What has been your experience?
Yes,
and what
ma'am.
have you observed?
Ma'am, actually, majority are head and neck carcinomas here in Northeast India.
Definitely because of the substance use.
Substance abuse. Actually, a great difference between Tripura side and the other, that is Mizoram Manipur side. It is like they consume tobacco, they chew tobacco. After chewing tobacco, in Tripura particularly, they spit that tobacco. So more number of oral carcinomas are there. Okay, but in that side, that is Mizoram Manipur side, they swallow that. So they experience more of esophageal and gastric carcinomas. So spectrum changes, but still majority head and neck cancers are there. But there is a wide spectrum of carcinomas to which we are exposed here. I have even got angiosarcoma, breast, those rare cases, and because I have seen only a single paper of angiosarcoma breast, not many. Then rare cases are there. We get adequate exposure regarding the rare cases, and the go-to cases, that is breast carcinoma, lung carcinoma, our brain carcinoma, then hepatocellular carcinoma, liver malignancies, then esophageal malignancies, bone tumors, liquid malignancies, lymphomas and leukemias, then GIT related malignancies, genitourinary related malignancies. Got adequate exposure regarding this.
So the next question I would like to ask you that if a junior who has just given the exam NEET PG and they are willing to look for the best institutes for radiation oncology, what are the equipments, technology, and the infrastructure which should be there in a good cancer hospital, and what all are available here, and what is deficient in our Agartala Government Medical College?
Our setup.
RCC.
Yeah. So I would highly recommend those students choosing radiation oncology as your branch. I'll give a myth buster here that radiation oncology greatly deals with physics and it is hard to cope up physics and so on. But it is not hard. It is not wholly related to physics. Physics is there, like in radio diagnosis, the amount of physics that is there, the same amount of physics is in radiation oncology. Not means we people of medical fraternity somewhat are afraid of physics. So I'll still say it is bearable. We cope up through that, and somewhere in our journey we enjoy those physics things, because reading just systemic oncology creates boredom.
Okay.
So just to refresh ourselves, we go through physics.
So what are about the equipments and machines? Like I've heard about LINAC,
Yeah.
Cobalt you told about, then SGRT. What was
SBRT.
SBRT. Just tell about
Yeah.
the things.
So actually, I would highly recommend those students to look for those institutes which have dedicated cancer hospitals. Cancer center should be separate, because the difference is when your department is integrated into the main college, so your frame of mind doesn't work wholly and solely according to an oncologist. The thinking doesn't go there. But practicing oncology in a dedicated cancer hospital changes your frame of thinking, means gives you a better oncology centric approach. So I would highly recommend that. Then in our institute, we have 2 linear accelerators, 1 cobalt machine, we practice brachytherapy, and we practice chemotherapy and other things. So, regarding SBRT, we do not have SBRT here. We have IMRT through LINAC. Yeah.
Can you elaborate IMRT?
Intensity modulated radiation therapy.
Okay.
So 3D CRT, IMRT, VMAT, we practice those here.
Okay.
SBRT in particular, or IGRT, image guided, or SBRT, stereotactic, we do not practice that here. But still, we got adequate exposure regarding both these modalities whenever we go for conferences or whenever we go outside. Our linear accelerators, those are 2 linear accelerators. One is TrueBeam, one is Unique, and Varian, we operate through Varian. Okay. There are 2, Varian and Electa. We operate through Varian. We practice brachytherapy here. Practicing brachytherapy in an institute nowadays become pretty rare. Not many institutes practice brachytherapy. But I am way happy with my institute. Because the recent machines, linear accelerator, we have those. The older machine, Cobalt, which forms our framework on which we build the overall setup regarding radiation therapy. So the Cobalt machine we have. A new Cobalt machine is also coming. Then for brachytherapy, we practice brachytherapy. Then a pretty rare thing, but still way satisfied. For 3 years, we practice chemotherapy, immunotherapy, targeted therapy. Because I'll say this thing, that in other institutes where you have medical oncology as a separate department, you don't get to practice chemotherapy, immunotherapy. These all comes under medical oncology. But all in all, we don't have a particular department here, so we practice. We practice means we are entitled to practice that, but medical comes under medical oncology. So if there is a department, they'll practice it.
Okay. So my next question to you is, do you often get chance or opportunities to go outside the state to attend conferences, workshops?
Yeah. Yes, ma'am. We definitely get those opportunities. We are even encouraged by our faculty members to go and present in those conferences. My assistant professor repeatedly pursues regarding paper presentation and regarding enriching our knowledge with current ongoing scenarios.
So have you been to any national conference till now?
Yeah, I have been to. I entered in 2013 October. Then in January 2024, I went for a conference.
Okay.
Just after entry. Actually, I am the first batch of radiation oncology here.
Okay. Tell me about the post PG career options after MD radiation oncology.
It is a branch where after you enter this branch, if you like this branch, you can continue your future in this branch. And if you somehow don't like being sitting on a computer and contouring and those all things, you want more of patient interaction, then you can go for DM medical oncology. Recently, our NMC has given the guidelines for super specialty, that medical oncology and critical care medicine, these 2 papers will be separate. Okay. So radiation oncology residents are entitled for DM medical oncology. Now we don't have to read whole of Harrison and compete with medicine people for our medical oncology branch. So the questions will be wholly and solely from oncology. Oncology centric questions will be there.
Do you know any premium institutes, like the top notch institutes for these DM programs, or even for radiation oncology as a PG course?
We all know the top institute, that is Tata Memorial.
Mumbai.
Tata Memorial. Then Homi Baba institutes, which are a part of Tata. Then BBCI, B Burwa Cancer Institute, that is in Guwahati, a unit of Tata. Then IMS BHU is a good institute. And
That Lucknow one?
yeah, HGPGI, good institute. Regional cancer centers, best institutes.
So the next question to you is that people often think before taking up radiation oncology that it might be very depressing to see patients dying because it is related to cancer and mortality is quite huge in amount. So how has been your experience till? Did it make you depressive, or like just tell me about your experience?
The outcome is not very good. Still, I have seen patients in stage 4 recovering from that, and that feeling of happiness is way exceeding. Surprising and exceeding. Not very good outcome because patients present in those late stages. None of the patients present in early stages. A very few, they have very good response, and those which present late have ambiguous response. Treated, some of them are treated, some of them even after receiving treatment, not a very good response in those. But still, not a depressing branch from my perspective.
So Shashank is fully satisfied and very happy with his branch.
Yeah.
So if a radiation oncologist specialist want to pursue other degrees, what degrees they can pursue outside India, or if they want to settle down, what is the scenario regarding those exams?
Yeah, we can practice in India in different institutes. Even recently, one of the NMC guidelines came in 2013, I think. So it stated that the government hospitals are required to have oncology unit. So oncology unit can't be a super specialty unit if you don't have a PG unit. So radiation oncology scope in government colleges is more. Then you can take, you can continue in government colleges, you can go into academics, you can go into research work, evolving, very much evolving branch. You can go into research work. Then if you think of settling outside India, then like MRCP and FRCS is there for surgeons and physicians. In UK, we have FRCR. It is for radiologists and radiation oncologists. Radiation oncologists pursue clinical oncology there. Yeah. So we can even settle outside India. If we want to continue from our branch, we can settle.
So what is your plan personally?
Personally, I will go for DM.
Okay.
I will go for DM.
And you want to stay in India only?
Yeah.
All right. So tell me, what do you do? What are your hobbies, and how do you pass your time?
After 4, I have time only.
Okay.
So
what do you like to do in your free time?
Yeah, I am more of a sport loving person. So I go play badminton, volleyball, and so on. I play. Then after playing, yeah, I am a bit television freak.
Okay.
Yeah.
So what was the last series you saw?
Last series, Family Man season 3, which came out just
And
recently.
do you like movies as well?
Yeah.
Okay. All right. So okay, tell me, because you're from Mumbai, so you're a Mumbaiker. So how Tripura has treated you so far in terms of cultural shock, or any culture shock was there, or food habits, and how have you adjusted?
Yeah, initially when I came here, it required a lot of adjustment because mainly in food. Food is drastically different here from where I come. Tripura is very nice, peaceful state, very peace loving, close to nature. And whenever you want, means the city vibes. Even Agartala has those city vibes. Not after 11, but before 11 it has city vibes.
All right.
So good.
So next question I would like to ask you is that because I'm a psychiatrist, I'm from psychiatry, so there is a thing called psycho-oncology, which is it has got very less attention when it comes to treatment scenarios. So in any institute, and how much knowledge you have regarding psycho-oncology, and whether it is practiced here or in other parts of the country?
Actually, psycho-oncology in particular is not practiced in our institute, but psycho-oncology is a part of treatment modality in other private setups. Private setups, they have psycho-oncology as one of the main treatment modalities also, because patient needs to cope up from whatever patient is going through along with patient's relatives. So the premier institutes also, they have psycho-oncology as a part of their treatment modality. The patient needs to cope up regarding that. It is a very good approach through psycho-oncology, which we take in counseling the patient, motivating the patient for receiving treatment, as well as motivating the family members to cope up with either both the outcomes.
So basically, we need to, as psychiatrists, we need to counsel the caregivers, patient also, how to cope up with the side effects and any throughout the treatment journey scenarios before the treatment when it gets started. It is very important to evaluate patient and how much care do they need, both caregiver and the patient. So my next question to you is that since it is cancer, and India is a huge has a huge population of cancer patients. So I would like to ask you, is there any stigma, and what are the in day-to-day life, what has been what has you have you noticed regarding the stigma related to cancer?
Actually, cancer, even now, it is not a widely accepted thing, because the fear of cancer is way more compared to cancer itself. So, but still nowadays people are more aware regarding this. So, like some of the patients are what we call self-aware, and some of the patients are more aware because of the recent advances in AI, as well as easily accessible Google.
Yes.
So patients ask regarding the treatment and regarding everything. But still, whenever a patient is diagnosed with cancer, patients have a setback, that will they be accepted in society? What if they will experience, they'll not tell anyone regarding if they have cancer or they are suffering from cancer, but there will be certain toxicities which will indicate, like hair loss. Many people know that chemotherapy causes,
Hair
or
loss.
treatment of cancer causes hair loss. So after hair loss, will they be accepted? Specifically females, regarding their aesthetics,
Right.
will they be accepted? But these all things are mainly dealt in psycho-oncology, as well as we counsel those patients, and we have them in confidence that these things are temporary. Main thing is your treatment. You should survive, so your hair will survive. So patient is important. Patient's mental status is important.
So my next question to you is that, is there any toxicity in the department regarding senior, junior, and how's the relationship with your, with your colleagues and teachers and everyone?
Actually, I am the first batch here. So I was directly under my assistant professor. He's a gem of a person. He teaches a lot. He guides through each and everything. Toxicity per se, I have never ever experienced it here. Never ever. Sweetest people of all. Even my juniors are very good. So not much of a hectic branch. So I would say not much of toxicity, and people here are very peaceful. So out of that also, then no way toxicity, nothing is there.
इसका gold medal पक्का है. Chalo. So my last question to you is that so now your juniors, super juniors will be coming. So what advice you would like to give them regarding our college, the cancer hospital, and the 3 year of journey in radiation oncology?
I really enjoyed my residency. Got to learn a lot of things, way lot of things, because in UG life we are not exposed much to either oncology or cancer or radiation oncology branch. But after entering this branch, after coming into this branch, I have enjoyed my studies. I have enjoyed this branch. I am satisfied with my branch. I have a good work-life balance. I have adequate time for my growth, for looking into my hobbies along with my studies and my goals. So I am happy with those things. And advice to my super juniors, not in particular coming to my college, but choosing radiation oncology, very good branch. I sincerely suggest this, that whichever branch you choose, don't choose out of your what we call that majburi, because the branch stays with you for your lifetime. If you are not enjoying your branch, you will not be able to survive that particular branch for a long time. Whichever branch you take, enjoy it. And radiation oncology, I suggest this branch. Those in particular who want a work-life balance or a life outside your hospital, I'll greatly suggest it. Patient interaction is there, other physician-related things are there, along with not a very hectic lifestyle, ma'am.
So thanks for coming and giving this interview oblique podcast. Thank you for giving your precious time. So here we wind up.
Thank you, ma'am. Thank you so much for inviting me here, for me to speak on radiation oncology, a branch which is not known during our UG days, and the students selecting it just blindly. So better to have a video on that and a look into our branch before choosing it. Thank you so much for the opportunity, ma'am. Ma'am is a wonderful, wonderful senior. Many videos are enriching, enlightening, and very educative videos. Like, share, subscribe.
बस कर पगले रुलाए का क्या?
Like, share, and subscribe. If you have any doubts, the comment section is open. You can reach either ma'am or me, both of us.
You can comment down below in the video, and he will respond to it surely.
Yeah.
So that's it. Let's pose for the thumbnail. कैसे pose करें? कुछ क्या करें? ये वाला करें. ये ठीक है. अब तक का सबसे लंबा